wall can have certain defects, either a weakness or a congenital opening through which a certain abdominal organs can come out of it. This is hernia. This is the basic definition of hernia. Now there are different classifications for hernias. For general having a good idea of this, we'll just go with external and internal hernias. The external hernias, mainly the epigastric, umbilical, inguinal, and incisional. Now these are the hernias which the general public, they know that some of their relatives or someone would have had this, so they'll be aware of these kind of hernias. And I will not be talking mainly on the internal hernias, the hiatus hernia, diaphragmatic hernias. I will not be covering those. The main scope of the topic today will be epigastric, umbilical, incisional, and inguinal hernias. Now, first, who can get hernias? The hernias can be in males, females, children. In other words, anybody can get hernia. There is no restriction that a person should not get hernia. Anybody at any age can get hernia. In males, inguinal hernias, that is the groin hernias, are more frequent, and they are more frequent compared to females. In males, it's most of the time it's on the right side, though it can be on both the sides. In females, the groin hernias are not so common. In females, it's more of an umbilical hernia, and in females, instead of inguinal, the femoral hernias are more common. Femoral hernias is another type of groin hernia, and in children, again, the male children are more affected than the female children, and females usually have bilateral presentation. That means they can get on both the sides. Now the question is, why do you get hernias? Now I told you that hernia means content is coming out. Now imagine abdomen is like a balloon. It's filled with air. A balloon is filled with air. If there is a small hole in the balloon, the air gushes out because that's the point of least resistance. The same thing happens in hernias. There is a certain defect in the abdominal wall, or there's a certain defect which is acquired by birth. Now these are the two spots which are little weak inside the abdomen. So when the pressure is exerted inside the abdomen, the contents of the either the intestine or organs, they try to come out of these through openings, which are providing a lesser resistance compared to rest of the abdominal wall. Now there are many factors which you can get. One is genetic or hereditary factors. That is, the abdominal wall can already be thin. In the fascias can be, the layers of the abdominal wall can be much thinner compared to other people, so it is predisposing to the hernia. If the patient is having chronic constipation, again the patient strains while defecating. Now while straining while defecating, it causes increase in the intra-abdominal pressure, and when the pressure increases, where does the hernia come out of? Wherever there is least resistance, it comes. Either it can be through inguinal, or it can be through umbilical, or anywhere in the abdominal wall. If there is certain previous surgeries done previously, it can also come out through the scar tissue over there. And next is the overweight. The patient, if the person is overweight, there is a lot of fat deposition in the muscles and in the layers of the abdominal wall, causing the strength to come down. So this again predisposes a person to develop an hernia. Not necessarily all the overweight people will get hernia, but it's a predisposing factor. And again, lifting excessively heavy loads. If you consistently lift weight which is beyond your means for a long period of time, again you are increasing the intra-abdominal pressure, and that in turn, if you are predisposed, you can get an hernia. Playing musical wind instrument, again here the intra-abdominal pressure increases while you are playing the wind instrument. Operations and injuries to the abdominal wall. Again, here if any surgery done on the abdominal wall, when the scar heals, that will not have the same strength as the rest of the abdominal wall. So that is the site of least resistance. So if the patient, for example, having a chronic constipation, let's say he's a smoker, he smokes a lot, so he's coughing a lot, and while passing stool, he's straining a lot. And if he's undergone a surgery, now easy for the hernia to come out through the scar tissue. The next reason is a pregnancy. In pregnancy, what happens, especially in the third trimester, because of the increasing size of the uterus, the abdominal wall gets stretched. The muscles, the rectus muscles anteriorly, they get pulled apart. So there, the linea alba, that is the fascia in between these two main muscles, they get stretched. Either this itself can cause look like a hernia, it's called as a divarication, or a hernia can develop through this weakness of the linea alba. So these are the approximate ideas you have got now why hernias can develop. What are the symptoms of hernia? Now see, in hernias, the symptoms are mainly either it's a pain or a swelling. This is the most common symptoms patient come with. But these symptoms also correlate sometimes to the stages. For example, in the initial stage, when the hernia comes out, it goes back inside. This is a very early stage. At this stage, the person will see either a small swelling or a bulge. And when he lies down, the swelling goes off inside. Usually, either he may or may not have a pain, and there is some kind of tugging or a pulling sensation felt around the hernial side. Either it's at the umbilicus or somewhere in the abdominal wall or in the inguinal groin region. And while the person strains, the swelling increases or the pain can increase. These are the indications that the patient has developed a hernia, and these are in the earlier stages. Now, what happens after this? Once in the early stages, if the patient tends to ignore, okay, there is not much pain, so let me wait until the pain comes. We tend to do that. Until the pain comes, we don't consider it as a main symptom. We don't consider the swelling as a main symptom because the pain is not there. This is how generally we people approach to that. So now what happens after a long period of time, the hernia has come out, but it's not going to go inside because at the opening, whatever the sac or whatever the content of the hernia which has come out, it gets stuck at that point. So when the person lies down, now the hernia is not going back inside, it is stationary at that point itself. Here again, the pain may or may not be there. Again, the patient tends to ignore if the pain is not there. We have seen many patients where there is a swelling is there, patient has ignored it for a long time. Why? Because there is no pain. Now, at this stage, the patient, when he lies down, the swelling does not go spontaneously. Again, the symptoms are there's a pain or some dull aching, stretching sensation. These are the things you will get. Now, even after ignoring at this stage, if the patient ignores at this stage, the next what happens, there is a lot of adhesions forming at the opening. And whatever the content which has come out, either it is a fat or it's an intestine which has come out, the blood supply to this structure gradually stops flowing into it. So what happens? The structure becomes dead. You can see that it's become gangrenous. That blue color it has become here. So once this develops, that means the intestine is dead. The problem here is if it perforates, it causes a lot of infection, the fecal matter to come out, and it causes infection to the entire body. Now, if the patient develops infection at this stage, now what we'll have to do, we may or may not do a laparoscopy. We will not be in a position to do the repair laparoscopically all the time. We may have to cut the intestine at this stage, fix the intestine back with staplers or sutures, and then we have to do an anatomical closure. Anatomical closure is basically closure of the hernia using sutures. Now, if we use a suture and close the anatomical repair, the chances of hernia coming back are very high. So the ideal repair for hernia would be to do a mesh repair. But if the person ignores the earlier symptoms and presents in the stage where it has already gone for gangrene, then we will not be able to proper mesh repair. And initially we'll do an anatomical repair, either a planned second surgery we'll do, or if the patient develops hernia at a later stage, only then we'll plan to keep a mesh. But the chances of hernia coming back in these patients are very high. So when do you consult a doctor? See, at the first sign of symptom, the symptom is either a swelling or a pain. If you notice a swelling, you consult a doctor. Don't wait for the pain to appear. The pain may appear at a later stage when it's all crossed the normal stages. So whenever you see a symptoms, consult a doctor. See, you don't have to consider that you meet a doctor, that means that you are going to go a surgery or going to get a surgery done. So you consult a doctor, find out what is the problem going on, and then you can think whether it requires intervention or not. Now, increasing pain suggests that the content of the hernia is going for complications, reducing the possibility of definitive mesh repair. I told you again, if the pain goes on increasing and if the blood supply is cut off to the content which is coming out, then a definitive repair will be very difficult at the stage. So most likely it will be again an anatomical repair. Now, have a discussion with the surgeon and confirm if the pain is related to the hernia. What is the size, has it gone for complication, and what are the options for repair? So you first discuss with the doctor and find out what is going on, what exactly is the problem. So after that, what the doctors will give you, he'll give you the surgical options. Now, the surgical options mainly you have are either a laparoscopic option or an open option. Now, what are the difference in between the two? A lot of people who come and ask that there are people who are doctors who are suggesting, can I go for open surgery? Why laparoscopy is better? No, you have to understand there are a few things in this one. In laparoscopic option, we operate using few tiny small incisions and then go inside a certain plane and put a mesh. In open option, what we do, we have to put a larger incision in the inguinal region or at the umbilical region, and then we have to go to a certain plane and place the mesh. In laparoscopy, the pain is far less compared to the open surgeries. In open, the pain is much more because there is a one single large incision. Now, laparoscopy, the hospital stays shorter compared to the open this thing. So you can most of the time what we do the surgery. Once the patient recovers from the pain, the next day itself the patient can go back. And in laparoscopy, because of the certain layers of abdomen we are going and keeping the mesh, we can go for a larger mesh compared to an open surgery. So that is why, considering all these things, we suggest laparoscopic option. And if you consider, can the hernia come back, whether it's laparoscopy or open, the chances of hernia coming back more or less are very similar. But with experienced surgeons, the hernia coming back in laparoscopy are very less. Now, in surgical options, I will discuss laparoscopy in inguinal hernias. We have two surgeries for this, that is TEP and TAPP. In both the hernias, we are finally keeping the mesh in the same location, but the approach to that location is through a different planes. These two planes are considered different. People have different presentations. For each people, we have a different way of doing the surgery. Now let's take a look at a picture of laparoscopic groin hernia. The first photo, what you are seeing here, is the early presentation, and we are doing a planned surgery. For example, you can see there is a hernia here and here. There's a small bulge over. Now this patient has presented at an early stage. For example, if you go in laparoscopically, how does it look? Now you can see in this point here, the hernia has gone inside here. This is the content which has gone inside here. Now if we laparoscopically, when we remove this off, this is the opening what we are seeing here. This is the hernial opening. Through this, the content has gone inside. So laparoscopically, what we do, we completely repair here and we place the mesh. You can see now we have placed the mesh here, and we have placed the mesh with some sutures, fixed the sutures here, and we have fixed it here. And then over that, we close the peritoneum. This is one type of surgery. In another type, we come to the same plane and place the mesh here, but we go through a different plane. So at the end of it, how does it look? You can see the incisions here. See, these are the very small incisions done here for laparoscopy, and the pain is very minimal. The patient can go back to work immediately the next day. That I will tell you later. Now I'll show you the video of a laparoscopic inguinal hernia. Let's run through this video. Here we're making a small incision at the umbilicus, and then we are going through that. See, this is the different layers of the abdomen we are dissecting inside. We are cutting all the layers. And this is the hernial sac, what we are reducing now. The contents of the hernia is being reduced. Now you can see the opening there. This is the hernial opening. The next step would be to reduce the sac. The sac has been completely removed. Now that is the hernial opening. Now the cord and the structures are being skeletonized now. Here. Now this is the final how it looks, and we are placing the mesh now. See, and we have used such a large mesh here, and we fix it here to the Cooper's ligament down and to the muscle above. There are a lot of people who use tackers for this. That is a metal tackers they use, or absorbable tackers. But then that will turn out very expensive for the patient. The specialty of GEM Hospital, what we do here is this intracorporeal suturing. So that way the cost burden on the patient is far less. This is the end of the surgery. This is very simple. It looks very simple because the people doing are very experienced. Now let's compare it with the open groin hernia repair. So now see, this patient has presented very late. You can see the scrotum is already completely blue in color. You see how much of the intestine has come down here. The repair is very difficult in this one. See, in this patient, when we went inside, look at the intestine color here. This is all the gangrenous intestine. This is the normal. The pinkish one is the normal intestine, and this the blackish one is the gangrenous. These are the dead intestine. Now what we have to do? We have to cut the entire intestine and remove. We have to join the normal intestine, and then we have to close it. But in this case, we will not be able to put a mesh because it's so much of infection can be there, and the mesh can go for infection. So we don't put a mesh in cases of late presentations. And look at the scar in an open surgery. Such a big scar. The patient will have a lot of pain, and the hospital stay will be longer. Chances of infection are higher. So that is why we suggest it's better to go for a laparoscopic repair. Now, this is a laparoscopic repair of abdominal ventral hernias. Ventral hernia is basically on the anterior abdominal wall, whatever hernia you can get on the abdominal wall. See here again, the initial photos are of different presentation. This is the first is the early presentation. Patient has waited a little longer and the hernia has become little more big. Here even more bigger. And see here, how much of the hernia has come out here because the patient has waited years together because the patient is not having pain. Pain is again, it's not a necessity for doing the hernia surgery. The swelling can be an indication for hernia surgery. So for that we need to do an evaluation with ultrasound, CT scan and all, and then take a call when the surgery will be done. And here is the port placement. See the incision, you saw how big was incision in the open surgery. Now look at the incisions and the port placements in the laparoscopy surgery. They're very small, tiny ports we are placing, and through this port itself, we'll do the complete surgery. Now again, in this ventral hernia, see the intestine are going through an opening here. This is the intestines here and this is the opening here. Now, once we reduce all the intestine, you see the opening here, it's such a big opening. Now, the specialty what we do here is the closure of this defect. If you see many places, including abroad, not many people were closing the intestine previously, closing the defect previously. This is a technique which has been developed in GEM and which has been copied worldwide. What we do is we suture closure of the defect. That is why OM plus, because we closed the defect. You can proline sutures, we have closed the complete defect. Now, because of this closure of defect, the chances of hernia coming back are compared to the if you keep the mesh directly without closing the defect. This is what we have developed here, and this is the final image where you have placed the mesh and fixed it. And the next important repair is something called as divarication of recti. Now here, abdominal rectus diastasis is a condition where the abdominal muscles are separated by an abnormal distance due to widening of linea alba, causing the abnormal content to bulge, abdominal content to bulge. Now again, mainly it is seen after the third trimester of pregnancy because of the uterus becoming very big. The abdominal strap muscles, they stretch away, causing the layers in between those two to stretch along with that one. So that forms a very weak layer in the center of the abdomen. So your there is a normal rectus muscle here in this side, and if you go down and see here, this is the amount it has stretched. And clinically, how it will look when the patient lifts their head on lying position, there is a big bulge here, or there is a opening like that here. So this is divarication of recti. See, this itself, it's not a hernia. It look like a hernia. This can be either a congenital, by birth the patient can have this problem, or commonly acquired during the third trimester of pregnancy, or if there is excessive weight gain by the patient, then again the laxity of linea alba occurs. Now, because of this laxity and the thinning of that linea alba, it is easy for someone to develop a hernia through this defect, through this weakness here. This itself is predisposed, and the weakness can develop through this over a period of few years. Now, this is a video of ventral hernia repair. Now, see how big the hernia is. The divarication recti with ventral hernia. Have a look at this. This is a big defect. Now see, we are reducing the defect laparoscopically. Everything is being done, and we are suture closing. This is called plication of recti. So we are going to plicate that lax linea alba layer, and you can see the hernia is also seen here. See, now when we pull it, the rectus muscles, they come closer. See, when he pulls it, the entire thing closes like a blind. This is a Venetian blind technique. Now, See, this is how it looks at the end of. You saw the bulge in the beginning. You see how flat the abdomen has become at the end of it, and then we put a mesh after that and fix the mesh with multiple. See, this is what I was telling. We put suture and close the mesh. We most of the cases we don't use tackers for the mesh. Tackers are they are guns which have clips in them, which will go and fix the mesh to the abdominal wall. This is mostly done when a laparoscopic surgeon doesn't have much experience in doing an intracorporeal suture. We use an intracorporeal suture and it's easy for us to fix the mesh. So that way we are saving a lot of cost to the patient. And then in children, yes, children can get inguinal hernia. I told you previously. It appears as a small soft swelling in the inguinal region. It reduces spontaneously again stage, and it can occur on both the sides. It's more common on the right, is more common than the left, and it can occur in either of the sex. And in children, we don't put a mesh. We just do an anatomy. As the age grows, as the muscle develops well and all the layers heal well, and chances of hernia coming back are very less. So most of the cases in hernia, we never use a mesh. In here, we can see again in laparoscopic approach, you can see this is the opening and see the intestine, the fat which has gone inside here. This is the fat which has herniated in. So when we reduce the fat, it will look like this small opening here. What we do, we just close. It's called as ileopubic tract IPT repair. We close it here. You have seen we have closed it with the suture. That's the end of it. That's it's a small procedure with 3 tiny incisions. We finish up the entire surgery. The patient can be discharged next day. So this is about the surgical part of the laparoscopic part of the hernia. Now, what are the precautions you take after the hernia surgery? Now, there are a few things what you can do. You can travel immediately after the surgery. See, we have many patients who are coming from different states of India. They get the surgery. Next day, if they're well, they take the flight or a bus and then they go back. So laparoscopic hernia gives you a big advantage because it's a very small scar. The pain is very less. You get the surgery done and you can travel immediately. And after that, what you can have your normal diet, but you'll be asked to take high fibers, but you can have your normal diet. There's no restriction as such for you can get back to your routine work. There is no restriction in doing the routine work. Your professional work can be done. You can join back to your work as long as it doesn't require to lift heavy weights. You can sit on the floor, you can climb the stairs. There is no problem with that one. You can drive or ride a vehicle after about a week's time. Riding, again, you don't have to kickstart because again it causes intra-abdominal pressure. If you do too much of heavy work too early, chances of recurrence are there. So you have to be very careful in the first few months of the after the surgery, and after about 3 months you can be almost back to normal. What you cannot do, lifting weights, and how heavy on the individual. A 5 kg can be very lightweight for one person, it can be heavy for other. Whatever is heavy and whatever is causing more pressure on your abdomen by lifting, please don't do that one. That can cause hernia to come back much earlier. Anything that causes increased pressure of your abdomen, no. And what you should do, very important thing, if you are suffering from constipation, you should take laxatives. This has the evaluation will be done prior to the surgery to see if any problem is there in the intestine. We do sigmoidoscopy for patients who are having constipation. We have a look at the intestine and then go ahead with the surgery. So if you're having constipation after the surgery, you should take laxatives and make sure that you're not having, you're not straining while passing stools. And if you're having any problem with micturition, you have to consult your urology doctor and you take medications and make sure that you're passing urine freely. If at all you develop cough or cold, it has to be consulted immediately and it has to be treated, because cough and cold again raises the intra-abdominal pressure and the chances of hernia coming back are very high. There are a lot of complications after any surgery. See, if you are doing any surgery, there will be certain level of complications, but if the benefit outweighs everything else, then I a big concern. See, during surgery, literally injuries can occur anywhere, whether you are doing open or laparoscopy or whatever surgery you are doing, whatever the structure comes along the path are potential possibilities for getting injured. But that is a very, very small possibility of injury. But more this thing will be the advantage of having a mesh and rectifying the problem you have. After surgery, patients tend to have very few patients tend to have chronic pain, and few patients will have recurrence, and there will be seroma formation. Seroma is basically a small collection in the site where the hernia has been reduced. In laparoscopy, it is little common to have seroma, but it's not anything of concern because most of the small seromas, they get absorbed on its own. If it doesn't, on an OPD basis, we just put a needle and aspirate it off. Hematoma, that is some little bit of bleeding can be there. That in all these things can be controlled. Very rarely small bowel obstructions can happen, infections, port site hernias can come, but these chances are very, very, very low in when we are doing in laparoscopic surgery. But then the small possibility is there. But the advantages of doing laparoscopic surgery outweigh everything else. Now, in finally, why is the best center for laparoscopic hernia surgery? If you see this timeline, in 1992 we have started the first laparoscopic hernia in India and in Asia. So we are one of the first centers to start an laparoscopic hernia repair. And we have more than nearly 28 years of experience in laparoscopic hernia. You have to see how many centers have 28 years of doing laparoscopic, and we have more than 50,000 hernia repairs done in all kinds of hernias. We have experience, whether it is simple hernia, whether it's a complicated hernia, the recurrent hernias, and any hernias literally anywhere in your abdomen we can repair it. That's the level of experience we have, and the techniques we have developed in GEM Hospital are being replicated all over the world, and we have numerous amount of publications and in journals regarding the hernia techniques what we have developed. So we are one of the best centers when it comes to doing a hernia surgery. Thank you. Heavyweight? Heavy weight lifting will cause hernia. See, heavy weight lifting can cause hernia. I will not tell it will cause hernia. See, if you have an weak abdominal wall and if you are lifting heavy weights for long time, yes, there is a chance for getting hernias. But at the same time, if you are doing a bodybuilding, your muscle tone is increasing in your body. That gives an added protection. So not necessarily you will have to get an hernia. But if you are predisposed by having a weak abdominal wall, or you have a inguinal canal which is already slightly patent by birth itself, yes, over a period of time you can develop a hernia by lifting weights. And if the age is higher and the abdominal wall is weak, yes, again you can develop a hernia, but not necessarily. Any diet to reduce hernia? No, there is absolutely no diet to reduce hernia. See, if once you have got a hernia, that means it is there. Only thing you can do is rectify that one. So it's not possible that you take a medication and the hernia goes back, or it's not possible that we change our diet and the hernia goes back. The only treatment for hernia is surgical option. There is no other options other than this one. No, IT professionals definitely will get hernia for 8 hours sitting job. No, absolutely no, not necessarily. See, hernia by sitting you will not get a hernia. By doing your IT professional job, no. But if an IT professional has got a hernia, you can repair and then go back to work the next day. No, pandemic has nothing to do with the hernias. Pandemic has nothing to do with the hernias. Pandemic, if you have to consider. So the question is, in the pandemic, hernias are increasing or not? During lockdown, people are lazy. See, if the people are lazy, that means they are not doing any work. If they are not lifting anything heavy, then they are lying down in one position. There is no scope for hernia to come. See, in lockdown, if you are doing a lot of heavy weight exercise because you have no other work to do, and again, if you are already predisposed to having a hernia in the abdominal wall, yes, you may get it. But no, that answer is no for that one. After pregnancy, all ladies will get hernia. How to avoid? No, that again it's a wrong concept that all ladies will get hernia. There are very few ladies get hernia. There are a lot of ladies who don't get hernias after that one. Some ladies again they are predisposed to that one after the around the third trimester, because of the size of the uterus. The rectus muscle slightly goes to the side. If it is a mild bulge, most of the cases we don't need to do anything. But if the bulge is significant, which is causing a cosmetic problem to the patient, or if there is pain to the patient, or if the patient develops a hernia on top of the bulge, then yes, probably we have to intervene. But as such, to avoid nothing, you can't avoid a pregnancy. Reason for hernia, I have already told you in the earlier slides. See here, again I told you, there is certain level of predisposition, that is either a weak abdominal wall or there is a opening which is there in the abdominal wall. Along with this, if the patient may have chronic constipation or cough, or they may be overweight, all this causes more predisposition by increasing the intra-abdominal pressure. Yes, those persons can get hernias, otherwise not necessarily. What? I am getting hernia after sigmoid colon surgery on the lower left side. See, if you're talking, I will assume that probably is you may have got a open surgery, and that would be called as a incisional hernia. I told you in the earlier this slide itself that after any surgery will never be as strong as your abdominal wall. So what happens over a period of long after a few years, you may get a hernia at the operated site, that is the scar site. So if that is the case, we may assess you first, and then we can plan it laparoscopically, and the surgery can be done laparoscopically. Thank you, everyone.